I'm going to go straight on and ask Ray Paul to come up and speak to you about access to Hepatitis-c treatment. Ray works for the Social Care and Health Trust and has been a significant supporter, along with the rest of the Trust, of SARG. So, over to you, Ray.
Okay, I like wandering around as well, so forgive me if I kind of walk across my slides as I'm talking. I also want to thank Jamie for inviting me to talk about my work. I'm a nurse consultant at the Hallamshire Hospital, and I work for Sheffield Teaching Hospitals, not Sheffield Health and Social Care, but that doesn't matter. But although I do work into social health and care as well. No, it's fine. So the title of my talk is really just about improving access to Hep-C clinics, which is kind of not a little undertaking, it's quite a huge task. And basically what I'm going to do is I'm just going to explain to you my work and my research, and also what I've done with that research in terms of work, in terms of trying to improve access to Hep-C clinics. So it's not just my own work as well, and I just want to acknowledge a few people, and some of these people are in the audience, which is good. So Dan Wolstenholme, he's the theme manager at the Clark, based at Sheffield Teaching Hospitals. Rebecca Partridge, she's a doctoral student and works in the lab for living at SJW. Thea Williams, who's a dear colleague of mine and is a social worker in our department. We're very fortunate in Sheffield that we have a multidisciplinary team that comprises of a social worker and a psychologist, as well as nurses and doctors and a dietitian. And Andy, who's sitting here. We involved Andy basically because it was very important to involve patient and public involvement in our work, and helping us to guide us in terms of what we were doing. And also there were key stakeholders that were involved in the workshops that we set up, and also there were service users as well, which was very important. I'm on a timer here. Oh, okay. I thought there may be people in the audience that aren't familiar with what Hepatitis-c is, and I'd be very interested to know if people could just raise their hands. How many people think you can cure people of Hep C? Okay, a few. Okay, so I need to wave my magic and just explain to people that you can be cured of Hepatitis-c. The majority of people can be cured of this. So the first thing to say is that Hep C is a blood-borne virus, so people acquire Hepatitis-c by coming into contact with blood that is contaminated with Hepatitis-c. Hepatitis-c basically infects liver cells, and basically the process that happens is your immune system, in terms of trying to clear it, can put people at risk of developing liver disease. Okay? So it's the act of your immune system trying to eradicate the infection that can subsequently lead to liver disease. And liver disease typically occurs over many years, okay? But it can be accelerated if people are co-infected with HIV and hepatitis B, or if people drink alcohol as well. It can cause liver disease to progress more quickly. The other thing about hepatitis C is that many people who are chronically infected have no idea they've got it because they don't feel ill, or the symptoms that they have may be fairly non-specific, and often people may attribute the symptoms to other reasons why they might, or expressing symptoms. So for example, a common symptom that people often complain about is that they feel tired, excessively tired, and that could be put down to other factors, including people's lifestyle, for example. Which leads on to the fact that the majority of people in the UK who acquire Hepatitis-c are people who have shared injecting equipment at some point. And it could be people who injected many, many years ago, who only maybe did it on 1 or 2 occasions, who have become infected. And it's those people that we really need to target and try and engage with services, as well as obviously people who are attending drug treatment services. As I've mentioned, it's curative, so for the majority of people, people can be cured of their Hepatitis-c, particularly with the recent advent of new drugs that will enable us to treat people without using interferon, that can have some quite challenging side effects. Now, despite a cure and despite a service in terms of being able to support people and help people through treatment, or even to be assessed for liver disease, there is a poor engagement, not only in this city, but also nationally, and also in other parts of the world. And I was keen to understand what that's about. Why is it that, although you can cure people of Hepatitis-c, why is it that people don't attend services? And if you look at some of the literature, the things that you tend to hear are things like, well, they've got a chaotic lifestyle, they're hard to reach, they're not bothered, etc., etc. They've got other priorities. So I decided to do a PhD to understand what some of the reasons were why people didn't attend. Now this diagram looks a bit, complex, so I'll just try to explain it to you. So at the end here we've got non-attendance, so I was interested in really what are the reasons why people don't attend, and is it really just that people aren't bothered, people have a chaotic lifestyle, it's not a priority, etc. When I undertook some telephone interviews of people who missed appointments with an outreach clinic, some of the things that they initially said to me was, well, it's not a priority, I'll forget, I'm not bothered, and there were other reasons as well, like, well, I felt unwell, or the weather. But then I was interested, well, really? Perhaps there's more deeper underlying reasons as to what this is all about. And that's when I started to untangle some of these kind of what I would call prima facie reasons. These are very surface reasons that people might often give quite quickly and superficially. And I ended up doing a thematic analysis, and I basically put the themes of non-attendance into two clear themes. One was about the characteristics of the people that I was interviewing. So for example, the themes within that are things like substance misuse. So people may have had an intention to attend an appointment, but they got waylaid by the drug dealer, and therefore they missed their appointment. There are other issues around comorbidity, both physical and mental health comorbidity, that kind of restricted people in attending an appointment. One of the other things was about income. People had other appointments to attend, and they had to decide which was a priority for them to use their limited income to attend. And also in terms of social networks, people described maybe family commitments or a lack of a social network that helped them to attend. And then the other issue was around the clinic service in terms of where it was located. And one of the big things was that for many people it was a difficult journey. Although it may not be many, many miles away, it was difficult because they had difficulty getting on and off several buses. They may have had difficulty walking, and it was also tied in with kind of psychological comorbidity, where people found it difficult to leave their house, or they were scared of crowds or meeting people that were new for the first time. And there was also about the delivery of the outreach clinic as well, that it wasn't tied in with their script, so it meant they may have to attend on a different day, or it was the wrong time of day, etc. Now, all of this, I would suggest, is influenced in terms of a wider context of factors, okay? And it relates to maybe a bit about what Chris was saying earlier about what good research. I don't know if it's good research, but I think you can't just look at these factors without considering the context in which they are kind of triggered or occur. Okay, so for example, the nature of hepatitis-c. I don't feel ill, so why do I need to go to a hospital? Welfare policy. So I'm thinking about the government welfare reforms, which slashed some people's benefits, which meant they didn't have income to travel to the clinic. There's things around addiction, stigma, the stigma of having hepatitis-c, even within the drug community. Things like drug policy, the criminal justice system, and health policy. So they all had a kind of wider contextual they were all wider contextual factors in the context of all this. Can you give me the next slide? So I completed my PhD, and I thought, well, okay, it all looks very pretty sitting on a shelf, so what can we do about this? Okay, and so I thought, right, what I need to do is see if there's any funding that would enable me to use the findings of my research to put some of the ideas into practice. So there's a funding stream within the Clerk called GRIP, which basically stands for Getting Research into Practice. And basically what they're keen to do is to implement evidence either from research or other sources and put some of those findings into practice. And I managed to get a grant for up to £12,000. And I sat with various people and we thought, well, how do we spend the money and what can we best usefully do with it? So what we did was we set up 2 half-day workshops and we recruited service users and stakeholders. So service users and stakeholders who had a kind of a direct involvement, not a direct, but or direct and indirect involvement with the Hepatitis-c service. So the first half-day workshop we spent looking at the challenges and barriers to engaging with clinics, and I was interested to see if those kind of views that people had within the workshop kind of were similar to the findings in my research. We used the idea of developing fictional characters within that workshop. So we thought it might be easier, rather than people having to necessarily feel pressured into sharing their experiences, they could use their experiences in developing fictional characters. So we ended up developing a fictional character about a person who may have a problem or difficulty attending the Hep C clinic and what their barriers might be to attending. We then used the second workshop to think about ways to improve engagement based on some of those barriers, and then we also identified some kind of myths or scare stories that might also have a bearing on people not attending the clinic, because they may have heard things about treatment, for example, or Hepatitis-c that may put people off. So I thought it might be helpful just to show you some pictures of the workshops, and we got people's consent to take pictures, and they were happy for us to share these with people. The way that we devised the first workshop, for example, was we asked the service users to work together and then the stakeholders to work together, and when we brought them together kind of from later on in the day, and then people shared their ideas. So these were the kind of fictional characters that we got people to complete and write, make notes in, and also we had magazines and pictures that people obtained from magazines that they could use to illustrate some of the things that they were trying to say. Okay, so what were the barriers that people within the workshops came up with? So this is the list, or the themes that we identified. So again, money was a factor, that people didn't feel they had sufficient money to be able to get to a clinic. That people identified a lack of support in helping people to get to a clinic. The nature of addiction itself, as we've already described. There was also, people felt there was a kind of a lack of information, really, or that the information might be inconsistent. So you might be told something by one person, and then you might hear a contradictory remark or a story about the information that had been given previously. So there was something about up-to-date information and it being consistent. Once again, a key feature was people's mental health and also their physical health. And that people struggled maybe to attend or engage with the clinic due to their physical and mental well-being. There was an issue about time, and I was thinking about this just now when I was listening to Chris's talk in terms of what did I mean by time. And I think time could be the time of when their appointment may have been, whether it was feasible or practical to attend, but also maybe having time to address this as a priority. The place, that was really interesting as well, because you would think, well, if you're providing an outreach clinic or some kind of service in a drug service, you know, what have people got to complain about? Well, often people don't actually want to be seen by a nurse from the service who's got about the hepatitis C within a service that they attend for their drug treatment. And actually, for a lot of people, attending the hospital would have been a better option because they felt that it's easier to explain that you're going to a hospital appointment, and also there was maybe a bit more anonymity. But also there were people who also found it helpful to see somebody from the service in the hospital into the drug treatment service. There was a real issue about transport, so people often didn't have their own transport, or they didn't have somebody that could help them with transport, and also there was the issue around money. And then we've also looked at some of these scare stories, so people identified some stories or myths or scare stories around hepatitis C and treatment, and part of our work from the workshop is to actually demystify some of those myths or scare stories, and I may allude to some of those in a minute. How are we doing for time?
5 minutes.
Pardon? 5 minutes, fine. So this was the second workshop where we were addressing some of the barriers and thinking about some of the possible solutions to what some of those barriers might be. And again, we kind of worked in smaller groups and then came together and shared the work that we had done in the smaller group. Right. So this is a summary table from Dan in terms of the outputs from the workshop. So I'm going to try and explain this. So there were some ideas about how we could try and improve engagement with the clinic, and we put those into kind of 4 key themes. Okay. So one was around incentives. The other one was around service changes, so changes in terms of how we deliver hepatitis C care and treatment. There was one about information, and there was also one about the environment in terms of the drug treatment service. And if we and I'm just going to go through these now. So in terms of incentives, these can be divided into rewards and enablers. So a reward is that you reward somebody for attending, whereas an enabler is that you actually help facilitate them to attend the appointment. So for example, a reward could be you give people money or a gift for attending, and the other things is that you provide them with refreshments, etc. And then an enabler is something like you would give them a bus pass for the duration of their care, or you'd arrange a taxi. And also you may give them phones, which might help in terms of communication. So, and it says here rate a test. So where we're at with this now is that we're running up a small feasibility project, or well, I am, at the moment at the hospital. And we're basically from this month up until the end of May, any referrals that I get where people have got history of drug use, then I will allocate them either a taxi, a £10 voucher, or a taxi and a £10 voucher. And this is put onto the letter, inviting them to make an appointment. So when we get the referral, we send a letter inviting them to make an appointment, and in that letter they will be told what they would be able to gain should they book and attend an appointment. Okay, and we're basically looking at the feasibility of offering incentives, and I'd be very interested to know from the people that do get the letters and people who do attend what they think might work best for whom, because I guess there will be some people who might think, well actually I'd have preferred a £10 voucher than a taxi, so I'd be interested in gathering that kind of information. In terms of service changes, the things that we were particularly interested in is this idea of a mobile bus, like a mobile van that goes around to various locations throughout the city. And the other one was around a kind of a buddy system where we would use peer support to try and get people engaged with the service. And what we're doing at the moment is we're working on a video using cartoons to try and graphically describe or depict that idea, because we see that as a long-term thing, not something that we're going to achieve in the short term. The other thing in terms of information is that using scare stories and demystifying some of the scare or myths around hepatitis C, we're going to devise some posters, postcards that could be used to facilitate discussion or make people aware of the reality of hepatitis C and not some of the myths that people may hear, and that's something we're working on at the moment. And then last but not least, in terms of the environment and maybe thinking about the Fitzwilliam Centre or maybe other drug services in other parts of the in other cities, thinking about the ways in which the environment and the culture can help promote the importance of addressing hepatitis C and engaging people into specialist care. Last slide. So after having written that, I thought, well, what's important in terms of summarising this and kind of reflecting on it? So my reflections of the work that we've done are, one, I've been really grateful for having the opportunity to put evidence into practice rather than having a PhD sitting on a shelf somewhere and not doing anything with it. And then the other thing that I'm grateful for is people giving up their time in terms of the workshops and service users engaging with the process. And also I was grateful for the strategies that people came up with when we devised the workshops in ways in which we could encourage people to kind of flourish and participate in the workshop. And finally, but not least, is the service users' insight and experiences. They were enormously invaluable in terms of helping us to understand what's going on. And that's it. Thank you.